Welcome. We start in 45 minutes. For what?
Тоді 2002-го, попри програш провладних партій на виборах, все ж кучмістам вдалося сформувати більшість. Звісно, долю вирішили мажоритарно. Тільки ось це людський гнів не погасило. Україна без Кучми трансформувалась в іншу антипрезидентську акцію «Повстань Україну». Продовжувало виходити на мітинги. Нелюбов до голови держави росла настільки стрімко, що породжувала просто неймовірні коаліційні покручі. Наприклад, Тимошенко, Симоненко та Мороз разом взяли штурмом національну телекомпанію України. Вони не готові до діалогу з нами, вони бояться. Вони не знають, що сказати тільки на народ України. Це через те, що телевізійники заплющували очі на демонстрації, розблокували роботу національного тільки після того, як тріо допустили на екрани. Але не так, як стала стопом політичних курйозів 2002-го. Захист Леоніда Кучма. Ні, він розпочав
інтернет-мем. Відома помилка Віктора Януковича в анкеті кандидата на пост президента України, де окрім неправильного написання свого вченого звання професор, він припустився до кількох інших граматичних та орфографічних помилок. Загалом у цій анкеті Віктор Янукович зробив 12 помилок у 90 словах.
Янукович, який ніколи не виблискував інтелектом, став батьком мерів. А Кушма цьому лише сприяв, наприклад, привселюдними вичерками свого прем'єра. Це ж було.
Чи не головний хід серед усіх серіалів 2020-го «Королева», чи як його ще називають, перезавидатний. Це історія про талановиту шахістку Бетгару. Персонаж хоч вигадали, але дістав минулу річ курсом.
Шахи також можуть бути
Серіал підняв колосальну цікавість на шахи. Останній в Україні таке було найновіше у 2002 році. Тоді паралельно до чемпіону світу мав точно стати українець.
Там шахової корони став львів'янин Василь Іванчук, партія якого стала прототипом фінального бою у серіалі, який міг зіграти одну з головних ролей у ході королеви. Мені написали на що позиції зіграти роль Боргову. Я таки одразу відповів, не знаю, що то таке, що то за телекомпанія, прийшло гроші тиждень, і як я отримав лист.
Good morning, Vlad. Are you there?
Hello,
Good morning.
good morning. It's after early afternoon here.
You're early today.
Yeah.
We
So
got a half,
I just joined. When do we start?
we start in 1/2 hour, 30 minutes.
Okay.
Okay?
Okay.
Okay.
Good. Okay, I shall mute myself and I'll be back in half an hour.
Okay. See you, bud.
Very good.
Mm.
Híjole.
Good morning, everybody. We start in 12 minutes. It looks like chaos now, but it is chaos. Get that out of there. Dr. Liao, are you there? Did you get in okay?
Hi, John. Good evening in Shanghai here.
Oh, how you
Can
been?
you hear me?
Yeah, I can
Yeah.
hear you.
Long time no see.
Let me get, I have other, okay. Yeah, Dr. Liao.
Yes. Yes.
Yeah, I'm
hello.
going to mention to Dr. Ben, we'd like to do a neuroanatomy series with Victor Hugo Perez.
Okay, I know him.
Yeah. Would you be interested in translating for that?
可以. Okay, I would love to.
Good. Let me talk to Dr. Ben, okay?
Okay.
Hi, hello.
Hey, Dr. Schroeder, how are you doing?
Good. And you?
Yeah, I'm John Bennett.
So busy with all these recordings.
123你听得到吗？
Amazing.
Yeah, I have some background here. Let me get some technicality straightened away. Yeah, it's early afternoon, and you're in Germany now, right?
Yes.
Gee, Greaseful. You've been spending a lot of time at home?
Yes, sure. No, not much traveling so far, but
Yeah.
I think it's improving now.
Yeah. It's, you can tell on the street. People are anxious. Juha should be here shortly. So you're way up in the, I look where Greifswald was. It's way up in the north, near the Baltic Sea.
Yes. That is a former
It just
East
looks
Germany.
cold. It looks cold.
Yeah. In autumn, from autumn to spring, it's pretty cold and windy.
Yeah, how close to the Baltic Sea are you? Is it right on the Baltic Sea?
Pardon? What?
Is it right on the Baltic Sea? The town Greifswald?
The Greifswald is very small. It's close to, to a bay of the Baltic Sea.
Oh, okay. So you get the wind off the sea?
Yeah, exactly. But in summer, it's sometimes nice.
Yeah.
Yeah, we can have over 30 degrees centigrade. The water is not boiling. It's still cool, so it's a refreshment to jump in.
I'm here, Miami Beach. It took me a while to get used to the sun and the heat. It gets pretty hot here. And especially the summer, it really gets hot.
I think I'm happy with the global warming. In a few years, we will have Mediterranean climate.
Yeah. Yeah. Yeah, this world is changing. The water levels are kind of funny here in Florida. They seem to be changing. Here's Juha now. again.
So John, how many recordings are you doing each week? It's a lot,
About
huh?
three or four. Three or
Yes.
four. Today there's two. Weekends obviously are busier. Fridays and Saturdays are big days.
Yeah.
You know, I think if you were going to choose to broadcast, it'd be better to do it a Tuesday or Thursday. You'd have less people out there, less, you know, webcasts out there. It'd be slower. Are you doing much webcasting?
We know.
You do some with Pakistan, right?
Yes, we had a seminar series from the IFNE about endoscopic topics, but we stopped because now there are so many webinars. So it's always repeating. That's why we made not so much anymore. And we have also from the European Scalpis Society, we had some webinars and then some local. But I think the Zoom webinars are very helpful because many people could not afford this traveling, and now they can have the same information to their home. So I think it's very, very nice. Although I prefer face-to-face meetings because of the social impact, the webinars are very helpful, especially for the young doctors.
Yeah.
It doesn't matter where they are in the world, can listen and learn a lot. I think it is very, very nice. I think also that the Zoom meetings will remain, even if we have in the future, again, physical meetings, we will still have a lot of educational events via the online.
I think this will be part of conferences. The virtual will be part of it, I think.
Yeah.
Maybe for people that can't come, that want to see it. Juha, I can't get Juha in. I don't know what's going on. Juha, can you hear me? Oh, I think you got in. There you go. Hello, Takashi.
Good evening. Good
How
evening,
you doing?
everyone. Yeah, I'm fine. Good evening. Guten Abend, Dr. Henry Schroeder. Ich freue mich Sie kennenzulernen. Ich heiße Takashi Kon aus Tokio, Japan.
Sehr angenehm. Sehr gutes Deutsch.
Yeah,
Dankeschön.
So how we should I talk very long, very slowly and you translate, or should I just talk the normal speed I do it?
So as for English, so normal speed will be fine. So I will translate into Japanese according to your speech. So do not worry. So normal.
Translate a neurosurgical presentation. Let's see where Juha is. Juha, you're here, Juha. Can you hear me, Juha?
He has still 4 minutes.
Yeah, he's still listening. He stays calm and cool. I get all nervous. I can see why he's good in the OR. Things go to pieces sometimes. I go crazy. He's just very calm.
Yeah, you have to.
Just wait. Well, with computers, I'm sure in neurosurgery you have moments where you have to just stay still. Same with computers, you know, it starts to go crazy. You got to try to keep your wits. And usually it works out.
Hi, John.
Hello. Hey, Harshad, how you been?
I'm fine. I'm fine. How are you?
Good, good. This is Dr. Schroeder from Germany. You probably,
Yes,
I don't know if you met him.
Yes, I know Professor Henry. He visited our Bombay. He operated also. And I'm a regular fan of him and attending all his webinars.
Thank you.
Welcome.
Henry, you remember you came to Bombay Hospital to do some cases and I with Leo Pujari.
Yes, yes, I remember.
Yes,
we had a very nice time.
Yeah. And you still quote that patient. I remember in your meetings.
Yeah, that was fun. Hi,
Yes,
Juha.
yes.
Hello, hello everybody.
Oh,
Hello.
Juha, you're here. You made it. Good.
Hello, Henry. Welcome.
Thank you.
Akashi, welcome.
Good evening. Good evening to you. Huh?
Good evening.
Okay, now we gotta talk to Ben. We gotta wait. How are you doing, Juha?
We are fine. We are fine.
Fine. Dr. Liao, are you there?
Yeah, John. Hello, Professor Juha.
Hello.
I'm afraid that Professor Bing's still in the OR, and I will be the translator tonight.
Oh,
Is it okay?
Great.
okay,
Great.
okay.
Okay, thank you.
Thank you.
Henry, Juha, hi.
Hello, Vlad. Hello, Vlad.
Hello.
Oh,
Hi, Vlad. I was very happy. I saw you around 30 years younger last time at the
when did it?
European
When was
Med.
it?
Same
Long time.
name. Huh?
Ah, very good.
Yeah, he did very well. Very good lecture.
Thank you. It was something from Uzbekistan, or Yoko has written to me about it. I must ask him.
No, it was at the European meeting, ANS.
Oh, yeah, yes. I see.
I just saw the name, Vladimir Benish. I say, aha.
Right.
And then he popped up. I say, whoops, he had the secret water to become younger.
It's true. That's true. The only thing is that I have more hair than he does. How's Greifswald?
It's good. A
Good.
little bit cold, but so far very good. Low number of COVID cases. Everything open.
Good.
Okay, we're gonna start now, Vlad, excuse me. Okay, to 10, 9, 8, 7, 6, 5, 4, 3, 2. Good morning from Miami Beach. It's Dr. John Bennett of Neurosurgical TV. We have another Juha's Neurosurgery Grand Rounds, and I'll just turn it over immediately to Juha. Good morning, Juha.
Hello, hello, John. Hello, Henry. Hello, everybody. So welcome. So we have the honor to have Professor Henry Schroeder. Nothing. No. Nothing. Today speaking, he will speak on endoscopic surgery in posterior fossa. So he has done this 20 years, and he has become one of the most specialists in this field. People around the world are coming to him to learn, also from China. Neurosurgeons have been learning from him. I know them, and they have told extremely good things about Henry's daily work. So please go ahead, Henry.
Thank you, Juha, for this kind invitation. It is a great pleasure to be here with you. And today I would like to give you my thoughts about endoscope-assisted skull-base surgery. I'm consultant to Karl Storz. Juha, I know you for many years. Even then you did not know me. I was watching your videos and have seen your lectures, and so it's very amazing. And this was in Jordan, maybe you remember, in 2013. And here you see him negotiating to make a good bargain with this boy. So my state in Germany is in the east and in the north, the former East Germany, here close to the Baltic Sea. Greifswald is a very small city. It's an old Hanse town. Hanse is a middle-aged trade organization around the Baltic Sea. You see here is the house of a mayor. This is our marketplace. This is a view from one of the churches to the bay of the Baltic Sea, which is here. It's the old Dutch bridge. So the city is small, but has the 7th oldest university from Germany, was founded in 1456. This is a hall where the celebration take place and the students get their academic degrees. And this is our new hospital, which was finished in 2008. So we have been done endoscopy courses since 1995. And in that time, I thought within 10 years, endoscopy is well established in neurosurgery and there's no need for any further courses. But you know, that's not the case. So we do still our endoscopy courses with a little bit better equipment. And I welcome you. I hope COVID situation will allow that next year we have our next physical hands-on course and you are all invited to visit Greifswald. So what is the concept of endoscopic microsurgery? That is the use of the microscope. The microscope has a very well visualization properties, has a very good illumination of superficial structures. You have a three-dimensional view. However, if you have small openings and have a long, deep and narrow surgical corridor, the illumination is very bad. You cannot look around the corner, and that is a problem. The good thing is you have a 3D visualization, high resolution, because the retina is your direct sensor. But we have a poor depth of field, so we have adjust the microscope always with a mouthpiece, especially when we're working with high magnification. And we have a poor illumination in these narrow surgical corridors. That is a major problem. With the endoscope is different. We bring the eye close to the lesion. We can have angulated scopes, may look around bony corners or behind neurovascular structures. And that is a big advantage of the endoscope. So we have a good magnification, we have a large depth of field, we have a wide angle view, and we have an angulated view. That is the advantage. So what we use is still 2D endoscopy. We have different endoscopes with different angles of view, 0, 30, 45, rarely we use 70, and they're very small, so they fit easily in between the cranial nerves in the posterior cranial fossa. And then, of course, you need angulated instruments if you want to remove tumor parts which are not seen in a straight line, but only under view of an angulated endoscope. That's why we have designed these curved curettes. And of course, you need a good camera. I'm still a fan of the HD camera. There are also 4K cameras, but it's not a big difference if you compare the images, and the color fidelity of this HD camera is really excellent. And if you go very close, you can even see erythrocytes running through the vessels in this craniopharyngioma patient. So a good visualization is, of course, key for this surgical technique. So initially, it was always a competition between microsurgery and endoscopy, but I think this is nonsense. You can have the same bimanual precise dissection. That is the most important thing. You should have the same accurate bimanual dissection. It doesn't matter whether you look through an endoscope or through a microscope. With a microscope, you have the advantage that you always see the structures which are in front of you. If you go deep down, like here for an epidermoid, the structures in front, like trigeminal nerve and facial nerve, are not sharp, but you see when you touch them. And that gives you safety. When I take the endoscope, it's different. As long as the lens tip is in front of the nerves, it's the same like with a microscope. But then I pass in between the nerves. I have a very good view in the depths, but I don't know what my shaft of the instrument is doing with these structures. And that's why we have to be very careful to not damage the tissue. You see, we go with the endoscope deep in. We see here is a remnant of an epidermoid. It's a contralateral part of the clivus. And with the microscope, I can dissect in the depths, but I don't see very well. But I see when I touch these nerves. When I switch to the endoscope, I have a perfect view in the depths. I can dissect on a direct view, but I don't know what is the shaft of my instrument doing. So that's why we have to be very careful when we're using this technique. The next point is the endoscope tip may become very hot. So the heat generation is tremendous. And that's why you have to irrigate all the time when you have an endoscope for a longer time in front of a nerve. Very important. So many people ask me, if you see so many advantages, why you don't do pure endoscopically, all these cases? And my answer is always, because I think it makes no sense. For example, this is a superficial epidermoid. It's attached to a small perforator. And I can dissect it very nicely under the microscope. It's a superficial structure. I have a bimanual dissection technique. I have a three-dimensional view. And I think it will not give any advantage if I place an endoscope and dissect this part of the tumor. It's different when I look around the corner. You see here is the epidermoid running into the internal aortic canal below 7 and 8. And of course, now it's nice. I have a 45-degree endoscope and I dissect the tumor below these nerves. Then I think it makes sense to use the endoscope. So that's why I'm a fan to combine microsurgery and endoscopy. I have used some 3D endoscopes. It is nice for teaching, but in the clinical routine, I still prefer 2D endoscopes because especially when you work in the nose, one lens is clouded by blood vessels, then always the image switches back and forth between 3D and 2D. And there are also some assistants, they cannot tolerate the view, they become dizzy. We have also an exoscope, which is under development. And you know, there are a lot of new exoscopes coming. And I can imagine in the future, we will replace the microscope. But so far, the microscope in my hands is still the better tool. So the surgical technique is that we start microsurgically. Most of the surgery, we dissect the subarachnoid spaces. And then we use the endoscope freehand for inspection. And if we see tumor remnant, which we want to remove, we fix the endoscope to this mechanical holding arm. And then we have a bimanual dissection, the same as we have under the microscope. And of course, for economic purposes, the screen should be directly in front of you. So some examples. Vestibular schwannomas are a good example where the endoscope is very helpful. When we have intrameatal lesions, we have to drill the posterior wall of the internal aortic canal, but still we have a blind corner to look to the fundus. And that is when we use the endoscope. You see, this is a 45-degree endoscope. You see, this was a tumor here in the fundus, and you see facial nerve and you see cochlear nerve. And here also we use the endoscope to identify open air cells. With a microscope, you have a tangential view, and it's very, very easy to overlook one of these small holes, and then you will get post-op a CSF leakage from the nose. So when we have small vestibular schwannomas and we want to preserve hearing, and the tumor goes to the fundus, then I think the endoscope is of immense help. So we place the patient supine, we tilt the head around 45 degrees, and then we turn the whole table even more, so we have no venous congestion. And then when we want to look to the fundus, we make a curved incision, which gives us a direct view with a microscope. Monitoring is essential, there's no question. And then we use a middle retrosigmoid craniotomy. It's a small craniotomy, 2 centimeters. What I like to use in these cases is suction spatula. The suction spatula has holes in the front, is connected to a suction tube, and will be fixed at the deepest point of our surgical field. So it's not to retract the cerebellum. The cerebellum goes down by gravity, but just is here to suck the irrigation fluid. And I like to dissect under continuous irrigation because this gives you the nice plane. You see the suction spatula is here. My assistant is all the time irrigating, and I can grasp the tumor with 2 forceps. I don't need to have a suction in my hand, and I can dissect the tumor exactly in the arachnoid plane from the tumor. So this is a very, very helpful tool for vestibular schwannomas, which are in the fundus or in the CP angle. So one example was a 28-year-old male. He had a hearing loss on the right ear, and then he got an MRI and had the tumor on the left. This was very surprising. And of course, because this is his only ear, he was, of course, very interested to keep the hearing. And then he was advised to get gamma knife radiation. You see the hearing on the right side is really bad. So when you look to the literature, the initial hearing preservation rate is good with radiation, but if you look to the long-term hearing preservation rate, it's very bad. It's just in 15 years, it's around 1/3 of the patient. So and he's a young guy, he wants to live with at least one hearing ear. So that's why we opted for the surgery, and he agreed. So we have here the bone which has to be removed. We cannot remove too much of the bone, otherwise we open the semicircular canal or the vestibulum, and then there's a risk of hearing loss. That's why we have to leave a little bit of bone, and then we use the endoscope. You see, this is done under the microscope. The medial part of the tumor is very well seen. We can dissect it under microscopic visualization. And then the last part, we cannot see exactly with the microscope. So it's a blind curettage. And then it's a time where we switch over to a 30-degree endoscope. And you see how nicely we can look into the canal. We can identify the plane between the residual vestibular fibers and the tumor. And we can dissect the tumor very safely because it is under direct visualization. So for me, these intrameatal tumors with hearing preservation are a very good indication for endoscopy. You see, now we can look into the fundus and we can make sure there's really no tumor there. This is the amount of drilling that we had. And this is hearing after surgery, so very useful hearing. And he's now 5 years after surgery with no recurrence. So in younger patients, we always opt for microsurgery. If we have older patients, of course, we can also send for radiation therapy. What is the strategy in large tumors? Initially, we place the patient the same supine, and then debulking of the tumor and dissection. But you see, I always have my suction because all blood is in the field. And this is something what I don't like very much. That's why we switch now to the hemisitting position as proposed by Majid Sami. And I think he's completely right in the larger tumors. We have the semi-sitting position. Of course, we have an endoesophageal echo to detect air embolism very early. And that is our approach. Of course, we have a little bit cerebellar retraction in this. That is true. We have other disadvantages like pneumocephalus, cerebellar retraction, air embolism. Pneumocephalus can happen in older patients. So in older patient, I would not recommend because the CSF spaces are so wide. And here we have a handrest. So for me, I have very long arms. It's not very disturbing to make sitting positions. Some people are complaining it's not convenient. I think it's okay. As an example, was a 13-year-old girl. She came with this huge tumor. She had still useful hearing on the right ear. So same positioning, opening. And then the first step is again, drilling of the internal arterial canal. So we always start with the drilling of the canal to identify the nerves within the canal. Then I use the stimulator to map the surface of the tumor to make sure that we have not dorsal course of the facial nerve, which may happen in rare cases. Then we have vigorous debulking of the lesion. And you see, I have always a good view because my assistant is irrigating all the time. I waste no time with bipolar coagulation. I just dissect with two instruments, traction, counter traction. Here is the internal arterial canal. You see, this is the facial nerve, stimulation. This is a residual vestibular nerve, which is removed. And this is a cochlear nerve down here. So again, here's a cochlear nerve, and you see, because of this constant irrigation and all irrigation fluid comes out from the surgical field, I have a very nice dissection plane. If you do this in a sitting position, in a supine position, you have always all the blood inside. And this is really not good because you have more manipulation to the nerves. This is a facial nerve running over the surface of the tumor. And you see how nicely I can dissect the tumor in the right plane with traction, counter traction. So I'm very convinced that for the vestibular schwannomas, which are large, it is much better. This is a facial nerve. You see, it's very flattened, but we did not have much response in the monitoring. We could dissect it in this arachnoid plane. And that's why we continue with the resection, had a gross total resection. If we have a very sticky nerve to the tumor surface, then we would stop to avoid a permanent facial palsy. But here we have a nice view. And this is a gross total resection. And you had a mild facial palsy, which resolved after a few weeks. And we could also preserve hearing. Is always gross total resection the aim? When I was a resident, it was always the aim. Tumor had to be resected completely. You see, she is 10 years, no recurrence. But you see, this is not a nice face. It is grade 2, but it's not nice. This is not what we want to have. We had this lady, she was taught, you have a large tumor and you will definitely have facial palsy. There's no chance to prevent this. Radiation is not possible, it's too large, and that's why she came to us. And then we make a sitting position again, and we dissected the tumor the same way I showed you before. But then we saw that the tumor is very sticky to the facial nerve when it enters the internal oral canal. And that's why we stopped the surgery and left a very small layer of tumor along the facial nerve. Here's still a good plane, but further up, there was no plane. I could not dissect the facial nerve. I had this response with the prognostic bad trains. And then we stopped. You see here, it becomes more sticky. And then because of the monitoring response, we stopped. And we had a small layer of tumor here along the course of the facial nerve. And this is stable since 7 years without any radiation. And she has a smile, what we like to see after surgery. Another case, 36-year-old male, large tumor. I also left a little bit of tumor capsule. This small piece was even not visible on the MRI, but I know it's there. 10 years out of surgery, no recurrence. Another lady with a cystic one, very ugly tumor, very sticky to everything. Same thing, sitting position. And you see, we left a small layer of the tumor along the facial nerve. And she has a good smile. And she is now, I think it's now 2 years after surgery. And so far, the residual, which you can see here, is not growing. So we always wait until we see recurrence, growth of this residual tumor, what we leave. And we had done this technique in the last 16 cases of the large tumors, and we had just one bad result, or we had one patient with grade 6. It's not included here. We had the largest disease. Now one is grade 6, but all improved to grade 1 or grade 2. So I think it's very good to preserve a very good hearing facial function if you make an incomplete resection. And so far we had just one case where the residual, what we left inside, regrow. So only one patient so far got radiation. And I think it's important, especially in the young patients, that we can avoid this unnecessary radiation. There's another patient with NF2, got radiation therapy on both sides. So the right tumor is stable, but the left is growing. She lost already hearing, and she has an almost complete facial palsy. So we open here, you see this is a tumor, this is the facial nerve behind the 8th nerve. Stimulation gave only a very weak response. So we open the internal oral canal with a high-speed drill. Resect the tumor with an ultrasonic aspiration. And initially I tried to preserve the facial nerve, but was no chance. It was almost completely destroyed. So we cut the facial nerve and make a total resection. Again, you see the suction spatula inside. So I have always a good view and can dissect the tumor completely from the fundus. My ENT colleague opened in the mastoid window and identified the facial nerve in the mastoid. You see, this is a stump of the facial nerve. So here we make a communication to his surgical field, to the mastoid. Then we measured the length of the transplant, what we need. So we took a sural graft. Five centimeters. Then here, this is a facial nerve in the mastoid. It's cut. And then we place it that the nerve is really, the fascicles are really side to side, not that they bend or so. It's very important. And we did not stitch it. We just fix it with fibrin glue. And then we put some fat around the opening that we created where the transplant goes in. This is the CT scan, this is the MRI. And 1 year after surgery, she has already quite good function. It is improving further on, but you see she can close the eye, she can smile. Okay, what is the other good indication except from vestibular schwannomas? Epidermoids, an ideal indication for endoscope-assisted surgery. That was a lady, she had 2 times a resection of an epidermoid. She lost hearing after the first surgery. And you see, it is a small tumor indenting the brainstem. And if you look to the coronal view, you see this part they could never get with a microscope, because when you make this supracerebellar intratentorial approach, it's difficult to look down. And that is a time where we can use a 45-degree endoscope to look to this area and remove the tumor in this area. So this an eye indication is an intratentorial supracerebellar approach, a lateral approach, which gives you good access to the lateral midbrain. You see there's a tumor. So my first question is now, where is the trochlear nerve? I cannot see it. So I have to be very careful. Maybe the tumor is close under this area. So we use an endoscope, 30 degrees, just to watch where is the trochlear nerve. And you see here is the trochlear nerve on the 10, then it makes a turn down and the tumor pushed it medially to the brain stem. This is information you don't get with a microscope alone. So now I know the tumor is far away. I can have a rapid and vigorous debulking of the tumor at the tentorial edge. The tumor is debulked and taken. You see here this I would not dare when I don't know where's the trochlea, but now I know and I can go ahead. And here in the back, we can identify the tumor. And this is the trochlear nerve coming here. And then, although it was a recurrent case, we were lucky we could dissect step by step, millimeter per millimeter, the tumor from the brainstem, preserving all pia mater. So we had a gross total resection of this tumor, which is not always the case in recurrent cases, but here it was possible. So we removed this part of the tumor, and now you see we switched to a 45-degree endoscope. And now I'm able to look in this indentation created by the epidermoid. And we were lucky here as well, so we had a good plane to dissect it under view of a 45-degree endoscope and could achieve a gross total resection, including the capsule. So in most of the epidermoids, it's not possible, and it should not be done if you see it sticky, because then you will have deficits. But here we are lucky, and we could resect this tumor completely out. And you see after, I think it's after 6 months or so, you see already the indentation of the midbrain has gone away. And the coronal view shows also a very good result. And it's now, I think, 5 or 6 years after surgery, and she has no recurrence so far. Another case is a 54-year-old female with facial numbness. And you see here, she has a huge lesion in the CP angle, compressing the brainstem. And she has another portion of the lesion, which is in Meckel's cave. And there is a tremendous dilation of Meckel's cave, showing it's a very slowly growing benign lesion. From the intensity, it's not enhancing. It's almost iso-intense to CSF in T1 and T2, a little bit hyperintense. So this should be an dermoid, not an epidermoid. Epidermoid should be identical to CSF. So it should be an dermoid. So what is the approach? Many people say, yeah, we make a combined approach, subtemporal, retrosig, transpetrosal, or anteropetrosal. Some people even say we make an endoscopic endonasal because this is a straight line. But I like to make it simple. We just made a retrosigmoid approach, removed this piece, and then we looked with an endoscope into Meckel's cave. This is the opening. This is the petrous bone. This is the tent, open of the arachnoid. You see there's some hair inside, fatty tissue. So it's a typical dermoid, can easily be removed. This is 7 and 8. So with bimanual dissection, we try to dissect the capsule from this tumor, and here is this fourth nerve, and now this is fifth nerve. So fifth nerve is very flattened by the tumor. So in a CP angle, we could dissect, but when it comes to Smeckel's cave, it was so sticky. So I made the decision to leave the capsule on the fibers, because otherwise I would destroy the whole trigeminal nerve. And you know, this deficit will not resolve. So we have a blind curettage because we could not see with a microscope, but you see with a 45-degree endoscope, it's so nice. We can look all the way into Meckel's cave. We see even the beginning of Meckel's cave and can dissect the tumor with curettes and curved suction and have a complete evacuation of the content. Of course, there is some capsule left, but as I said, it was so sticky. If I take this out, the function of the nerve is gone. In this MRI, you see completely evacuation of Meckel's cave, and she had a resolution of her numbness. So this was a 67-year-old female, progressive gait and balance problems, and dysesthesia in the left arm. You see, this is the foramen magnum meningioma anteriorly located. Also in meningiomas, I frequently use the endoscope in the skull base. So what is the best approach? I think everybody of you will agree. The dorsal approach is not so good because the tumor goes far in front of the brainstem. So we come from a left far lateral approach. What I never do is I don't take the condyle. This is my opening. You see, this is spinal accessory. This is a tumor. And then I dissect the tumor under microscopic view. This is good visible with a microscope. I dissect it from the brainstem by manual dissection. Tumor was soft. That is very good for us as surgeons. Tumor is removed, but you see now I have a blind area in the frontal part of the foramen magnum. So I don't need to drill more. I just take a 30-degree endoscope. I fix it to my holding arm, and then you see under endoscopic visualization, I can resect the inner layer of the dura with the tumor, and then the periosteal layer is coagulated. So the endoscope saves a lot of time because I don't need to drill too much of the condyle in the skull base because I look simply around the corner. This is a microscopic view. You see, I cannot see this area, but with the endoscope was very nice. This amount of drilling, you see, I stopped just behind the condyle, and there's a gross total resection, and she was doing fine. It's another lady with a lot of symptoms: headache, facial palsy, hearing loss, dizziness, and she has a petroclavian meningioma. And petroclavian meningioma is a lot of discussion. What is the best approach? Initially, it was always done by a transpetrosal approach, and then more and more people came back to retrosigmoid. I have done only retrosigmoid. Some exceptions, I made a Cavazzi approach for some tumors which are more located in the upper part of the clivus and even going supraclival. But in these tumors, I always did the retrosigmoid approach. It's so easy. And I think the tumor gives you the space you need. That's why we just do retrosig, same positioning like for the vestibular schwannoma, almost the same incision. Monitoring, of course, of Dutzen's nerve is essential. And then this opening about 3 centimeters. We see here is a dura. It's very important that you go very close to the sigmoid sinus. Sometimes you see patients had previous surgery and they did not go to the sinus. And then, of course, you need too much retraction. You see the lower cranial nerve group, the 9th nerve, 10th nerve, opening the arachnoid, dissect the arachnoid plane. This is 7 and 8. And then you cannot simply coagulate because through the tumor are small branches from the ica or pica. So you have to be very careful, step-by-step mobilization. And always I dissect first with a dissector before I coagulate in the base because somewhere is the abducens nerve. So I want to see the abducens nerve at the brainstem first, and then you know where it is and you can follow it. So not simple coagulation, otherwise you will damage it. You see the tumor, the nerve is running through the tumor. Careful dissection. There's not infiltration, so there is a plane, so I can dissect the abducens nerve. Then we come to the upper compartment. You see this is a tent. trigeminal nerve displaced anteriorly, debarking of the tumor with the Cusa. And then we go up here under the tent, looking for the trochlear nerve. See, this is a trochlear nerve coming here. Careful dissection. Sometimes you have to incise the tent if the tumor goes far up, but in this case, what not necessary. And now you see the blind corner again. There is tumor within Meckel's cave. Of course, there is also infiltration. You cannot remove everything, but you can make a good decompression in this area under endoscopic visualization to decompress the trigeminal nerve. And this is then after resection. 7-8, fifth nerve. This is oculomotor nerve. This is thoracic canal. This is oculomotor nerve. This is superior cerebellar artery. So it gives you a good overview. So I think for most petroclavian meningiomas, the retrosigmoid approach is okay. It's a near total resection of the tumor. She has an abducens palsy and light facial weakness, but this resolved after 3 months. When we use the retrosigmoid approach again, was a young lady with a lot of problems of the brainstem, and she presented with this large cavernoma. She had but obviously she had two bleeds. What is the best approach for these? Some people say subtemporal. That is certainly an option, but you see when you come from here, you have a vein, a big vein running on the base, and this is in your way. Of course, you can dissect it from the skull base, or you dissect it from the brain, but it is in your way. So what is an alternative? It's just to make a retrosigmoid approach. The same approach. We're on the left side. This is 7 and 8, and you see there's a bulging of the brain stem from the cavernoma. So cerebellomedullary fissure splitting. We go to the cerebellar peduncle, and then under navigational guidance, we go through the peduncle to the cavernoma. It's a long way, but it is a good way because it does not cause any problems. And then the cavernoma is resected. Of course, you cannot use an endoscope because if you bring the endoscope in this hole, you cannot move your instruments. So all the dissection is done under microscopic view. You see there is not only a bleeding inside the capsule of the cavernoma, it's the bleeding outside of the cavernoma. So we have to be very careful that we do not damage the brainstem. And then you can use an endoscope to have a better look into the cavities. It can be done, but no, not a resection under endoscopic view. This is the fifth nerve, and you see now the relaxed brainstem. And this is the approach. It's far lateral, goes through the cerebellar peduncle. And she was doing fine with improvement of her symptoms. And 2 years ago, I met her at the petrol station when she going for a snowboard tour to the Alps. So it must be some good function, I think. This was an interesting case I want to show you. This was a 20-year-old male, sudden ear pain, tinnitus, hearing loss, facial palsy. And he came with this lesion. So you see it's a dilation of the canal, so it must be a benign lesion, but the enhancement was very strange. So I said, I don't know what it is. The radiologist said, maybe it's a vestibular schwannoma. It looks so different. I say, it doesn't matter. He has problems, so we have to look. So we made a retrosigmoid approach. And we looked, you see the ICA in the canal as usual. No big deal. So we open the canal with a high-speed drill. Then we resect the intrameatal dura, and I split in between the vestibular nerves. And this is a bluish shining lesion, very strange. And here you see it seems to come from ICA. So I cut the vestibular nerve because it was working. It was not working according to the examination before. And then you see it's a broad-based ICA aneurysm, a thrombosed intrameatal ICA aneurysm. Very strange findings, not much cases reported in the literature. So we mobilize this mass from the canal. This is a facial nerve. So what should we do now with this lesion? So we incised and make an arteriorectomy, removed the clot. And then you see it starts to bleed, the proximal branch. So we place a temporary clip. And then we dissect also the distal branch and get a little bit back bleeding. So thrombus was removed. Temporary clip is placed. Then the aneurysm is excised. And then is the question, should we reconstruct or not? Because there was some back bleeding. But I think if we can restore the vessel, we should do it. So we make an end-to-end reconstruction with end-to-end sutures. At first, the anterior wall of the vessel is sutured with 10-0 sutures, interrupted, no running sutures. Then after the last knot, I tilt the aneurysm clips to come to the posterior wall. And you have to be very careful that you do not stitch the anterior wall together, of course. And then we got the reconstruction of the vessel. First removing of the distal clip, a little bit bleeding, but stopped after a while. Then we remove the proximal clip, and then microdoppler shows a good result. And then we had the ICG angiography to confirm that we have a good functioning anastomosis. And he's doing good. Facial palsy resolved. Of course, he remained deaf. So for aneurysm clipping, I also use the endoscope at some indications. It's rare. It's around, I think, 12 to 15%. This is one example. This was a lady. She had an unsteady gait, dizziness, balance problems. And you see there is a lesion pointing to the brainstem, causing edema in the brainstem. It's very interesting. You see, this seems to be vertebral artery. This seems to be pica. Then we made angiography, and it confirmed the vertebral coming. This is a pica with a sharp angle. So our interventionist said, when I call this aneurysm, there's a high risk that the pica will be occluded. And that's why she was sent to us. And we did a surgery. Most of the time I do the surgery from a suboccipital midline approach, but in this case, I made a lower retrosigmoid approach. But this was not a good idea, because you see with the microscope, I could not see the aneurysm. So I had to use my 30-degree endoscope. I see the vertebral arteries coming. This is a pica, and this is the aneurysm. And if I go further, I want to see where are the perforators. And you see here, perforator running. So now I have an understanding of the anatomy. Then I tried to clip the aneurysm under endoscopic visualization, but when the endoscope was in the field, I could not come with my clip applier. That's why I had to switch back to the microscope. I have to dissect the aneurysm from the brainstem, had to mobilize it because it was really pointing to the brainstem. And then I took a straight Yashagil standard clip, and I clipped it parallel to the vertebral. For my endoscopic visualization, I have an understanding of the anatomy. So I clip it, but you see, I don't see what is the clip branch doing in the depths. So I have no idea, is the aneurysm completely clipped or not? Is there a perforator in? So again, I take my endoscope, I see the clip is in correct position. Perforator is not in the clip, but the aneurysm is completely occluded. So it's very helpful when you cannot overlook the aneurysm, you cannot move the vessel where the aneurysm is on, then the endoscope is very helpful to give you some more information so that you have a good clip positioning. The last field I want to mention is microvascular decompression. We do a lot of microvascular decompressions, and I think the endoscope is extremely helpful. Trigeminal neuralgia, for example, we make a superior retrosigmoid approach. This is our positioning. We make a small, straight incision in the angle between transverse sinus and sigmoid sinus. And then when we have the problem with a prominent suprameatal tubercle, the endoscope is very helpful to enable a look behind. You see here a case, very prominent suprameatal tubercle. I see just the root of the fifth nerve, and I see SCA. So I think maybe there's a compression here, but I don't see. Now I take an endoscope, and you see the problem is not the artery, but the problem is a small vein, which is indenting the trigeminal nerve at the entrance into Meckel's cave. What is our surgical technique? So what we do usually is a transposition. This is the opening. You see the petrous surface, the tent. We mobilize the SCA widely. You see with an endoscope, we see it's a severe compression of the trigeminal nerve by a SCA. And we look to the back because we dissect always the SCA far in the back. I always preserve the superior petrosal vein. If it's small, there's no need to cut it. If it's very, very prominent, I think it's not a good idea because problems may occur. So I mobilize the SCA from the trigeminal nerve. All this done under the microscope. And then when everything is mobilized, I make a transposition. That means the vessel, which is sticky into the trigeminal and the trigeminal nerve, goes up, and the vessel goes along the tent. You see here, now I pull it behind. This is superior petrosal vein. I pull it behind, that the loop, which was in the nerve, goes up. And then I like to have a sling. Usually it is Teflon because softer. Sometimes I take Gore-Tex, but Gore-Tex is too rigid. I think it's better with a Teflon. Then the tent is incised. And then I create a pocket for my aneurysm clip. Initially, I also always made sutures, but if the suture is not in a good place, you have to cut it, make a new one, and the clip, with the clip, it can be easily adjusted. And then we check again, you see trigeminal nerve is completely free. So for me, the best decompression is if there's no contact between the vessel as well as the Teflon. If you just put Teflon in between, it can be done, but I think then the risk for recurrence is higher compared to the technique when you make a sling and you have the vessel completely away. So the nerve is completely free. So for me, that is the best. What we do when transposition is impossible. You see, there was a 71-year-old male and he came with a megadolicho basilar artery. And you see severe compression of trigeminal nerve with bowing of the nerve. What do we see? We see 7 and 8. This is abducens and this is fifths. So everything is stretched over the artery. There's no chance to make a sling or so to bring it away. So the only chance I thought is to decompress the root entry zone. So we mobilize the Eiche and we mobilize the basilar artery, and then I just place Teflon in between the brainstem and Eiche. I think the main problem was the Eiche loop. So we placed it here, and you see now the vessel is away from the entrance zone, and then I put another small piece in the middle of the trigeminal nerve, but you see there is still some squeezing of the nerve here at the entrance. So I was really concerned that this will not help. But I contacted him around 3 months ago, and it's now, I think, 6 years after surgery, and he's still without any medication and has no pain. And some patients, when we don't see a cause for the problem, and the pain is in the third branch of the trigeminal nerve, also in cases with multiple sclerosis, we make a rhizotomy of the lower third. Even in an MS patient, it is working. This is interesting. So here we identify the lower third, and then we cut it. And it's interesting is really we have good results with this. Even with MS patients, although we think the lesion is in the brainstem, obviously the efferent signal, which initiates the pain, is blocked, and that's why they profit from this. One question which is always discussed when we talk about trigeminal neuralgia is, when we have a venous compression, is it safe to sacrifice a vein? And many people say, yes, nothing can happen. You can sacrifice, no problem. So we had this patient, you see there is a vein here, and there's another vein exactly at the entrance into Meckel's cave. So in this case, under endoscopic visualization, we coagulate the vessel, shrink it down and size, and you see there's really a grooving. So that for sure, there are cases where the problem is not occurring at the root entry zone at the brainstem, but it's a peripheral problem of the trigeminal nerve. We have several of these patients which had a very good outcome when you take it. The question is, for me, is can we take these veins? This was a lady also with a vein here at the trigeminal nerve. You see here, very squeezing of the trigeminal nerve root, and I was very brave. I just coagulated it. And then after surgery, she had a lot of brainstem symptoms and had this diffuse swelling. I was very concerned that she get the hemorrhage. You see, 5 days swelling here, and she had really double vision. She has dizziness. She had walking problems, and I was very afraid. So obviously this was not a good idea. So you cannot take all the veins. You must be very careful. Another patient has here clearly a vein close to Meckel's cave. So we look in, you see, it looks pretty the same, the case I showed you before, but now I was not able just to coagulate it, but I want to check. And you see here is a second branch running from here and entering at the area of the superior petrosal veins. So as one outflow is here, the other outflow is above. And you see, this is a clear communication. So the vessel is going from here, going that way. And because there was a collateral in this patient, I made the decision, okay, if there's a collateral, it's safe to coagulate this vein. And then I dared to coagulate this vessel to free the trigeminal nerve coagulation, and then I put some Teflon because the other branch of this vein is running along the nerve. But you see, this is the collateral outflow. If I would not see that this collateral is there, I would not, of course, not sacrifice this vein anymore. I think it's very important that we have to look, do we have a network? Is there collaterals? Frequently it might be, is there, but not always, as our case has shown. Fortunately, she recovered very well. In hemifacial spasm, the use of the endoscope is also extremely helpful, even more than in trigeminal neuralgia. The approach is an inferior retrosigmoid approach. There's a positioning, again, the same like for trigeminal. The incision is a little bit more lower. We don't need to see the transverse sinus, just an approach to the lower cranial nerve groups. All of these cases were done under monitoring of the lateral spreads. Lateral spreads is a pathological signal which is recorded when you stimulate. After surgery, we want to have this line, then we are happy, lateral spreads are gone, and it's a prognostic factor that you have a good decompression. It's a small approach, it's not much space needed. And then you see, when you open the CSF in young patients, you have only a little bit of space to work in. And again, the question comes, why are you doing it all endoscopically? Because I think the initial phase of the surgery is much better when we dissect the arachnoid under microscopic view, because there's no space for the endoscope. Only when the CSF spaces are open, cerebellum is relaxed, then of course the endoscope is extremely helpful. This is a view with a microscope. You see there is a loop of an artery. This is the facial nerves. There might be some compression. Now I switch to the endoscope, 45 degrees, and you see very nicely, here's the basilar coming. Abducens nerve is a common trunk, gives rise to Ica and Pica, and this is a compression. So the endoscope gives you a much more detailed view of this area. Then most of the time I switch back to the microscope, mobilize the vessel, put some Teflon, and then with the endoscope I check whether the Teflon is in good position. What is the best position of the Teflon? It should not be just in between the compression site and the vessel. as I think it's very important that you leave the original compression site free. So I placed my Teflon mainly not on the facial nerve, but on left side or right side. Sometimes you have to put it on the facial because the vessel runs in parallel exactly in this direction of the fascia. Then of course you have to put it in between, but if possible, try to avoid to covering the original compression site. So it's one example. The arachnoid is opened. You see there's a major compression, not just a small artery, but the vertebral itself. You see this is the facial nerve, 8th nerve, and you see severe compression directly by the vertebral. If you just place Teflon in between the vessel and the brainstem or the nerve, I think there was still too much pressure, and I would be afraid that you get a recurrence or even from the beginning not a good result. That's why in these cases I usually place a sling to keep the vessel away, because I think the pressure is too strong. So also in this case, it's a Teflon sling, it's mobilized. Then I create the pocket in between the internal artery canal and the jugular foramen. Then I can place a clip. And the good thing is, if I see it's too tight, I can loosen it a little bit, or if it's too loose, I can tighten it a little bit. Now, when you make a suture, then it is not possible. And you see it looks very good, no contact to the facial nerve at all, and it's kept away. Sometimes, of course, we dissect these vessel under endoscopic visualization if we cannot see it very well. This is a high-rising pica loop, goes high up into the pontine area. It's very far medially. And if you look from here with a microscope to see this compression, you have to retract a lot. And that is, of course, not good. That's why in this case, you see here, this is a vertebral. The compression site is down here. I cannot see it with a microscope, even if I retract. So that's why I switched to a 45-degree endoscope. You see, this is a vertebral artery, and here is the pica origin and going exactly to the facial nerve, indentating the brainstem severely. So the endoscope is fixed with a mechanical holding arm, and with the bimanual dissection, the vessel is mobilized from the brainstem. You see how far it went in. And the endoscope was extremely helpful. So for these steps, of course, the endoscope is ideal because you cannot see it with a microscope. And now the loop is pulsating here into this direction. It's not damaging the nerve again. So sometimes we had very strange findings. This was a 32-year-old male. He has a facial nerve which runs much more anteriorly than on the other side. So there must be some problem during his brain development. And he has hemifacial spasm since he was 12 years old. And when we looked inside, you see that it's like a strangulation. This is the 8th nerve, 7th nerve, and you see here, it looks like a centaur-like nerve. This is a nerve coming up, and here it's like a strangulation. There was no vascular compression of this nerve. It was just a strange shape of the nerve, which has obviously a developmental problem. So what we do is we just open all these arachnoid fibers around. So we cut the strangulation to release the nerve, but you see how thin the nerve is. So we dissect all the arachnoid, which is strangulating the nerve. We incise with a diamond knife the perineurium to release this constriction. And then he improved from the day after surgery, no spasms anymore. And then we have a second patient. He also has this strangulation. You see these arachnoid fibers. This vessel was not compressing the nerve. This was a problem. So we just cut all the arachnoid here and he was also improving immediately. So it's not always vascular compression. So in our series of 387 patients, we had several patients which needed a second surgery, and this was because the Teflon was irritating the nerve. So in most of these cases, we just removed the Teflon from the nerve, and then the spasm resolved. What you see also is the duration of the symptoms. The patients come very late, sometimes after 35 years. And you can imagine if the nerve was irritated for so long time, the results are not optimal. That's why we always advise to have an early surgical procedure, but the neurologists, you know that maybe in your countries it's the same. They don't want to send the patients. They prefer the Botox injections. Most frequent vessel in our series was pica and ica, and a lot of combinations, but we had only just one purely venous compression, and we had these two arachnoid bands. So what are prognostic factors? What we found in our last evaluation is when we have a central grooving, that means exactly at the pontomedullary sulcus, and we remove this pica loop, all of these become very good. Usually they become spasm-free within a short period of time. But if we have a peripheral grooving, that means it is distal, at least 5 millimeter distal from the sulcus, like you see here, or even here, 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 then the recovery is worse compared to the whole series, and especially compared to the central grooving. It's very interesting. Obviously, the regeneration of this part of the nerve is different compared to the central part. So we have done a lot of endoscope-assisted microsurgeries, mostly a semifacial spasm, vestibular schwannomas frequently, also epidermoids. So I think that the combination of endoscope and microsurgery is, at least in my hands, the ideal combination. I don't want to make purely endoscopic surgery if it's not needed, because a microscope gives you such a nice view. But the endoscope enables a look around the corner. I think I can do the same via small standard craniotomy, especially in tumor surgery, what other people do with extended skull base approaches like transpetrosal approach. That I think is a big advantage of the endoscope, that it gives you the ability to see hidden corners which you cannot overlook with the microscope. So I thank you for your attention, and I hope I can invite all of you to our next course in 2021 in Greifswald. Thank you for your attention.
Thank you, Henry. Thank you very much for wonderful lecture and skillful surgery. So there are some comments or questions.
Everyone's quiet today.
Once more, thank you very much, Henry, for excellent lecture and good surgery, great microneurosurgery. Some questions?
I'm happy that everybody seems to be convinced of the technique. That is very
good. 100%. Harshad has a question. Go ahead, Harshad. Can you hear me, Harshad?
Hi.
Hi. Hello. Yeah, go ahead. Go ahead. We can hear you.
Yeah, excellent presentation. Yes, wonderful talk has been given, and we all have understood the value of endoscope in assisting the microneurosurgery. I was just wondering, who holds your endoscope while you are dissecting with the two free hands?
I fix it to a mechanical holding arm usually. If I have a very experienced colleague of mine on my side, then he can holding it. So for the frontal skull base, for example, frequently my assistant is holding it. But for here in this case of a CP angle, where you have not much space and is not much error is allowed when you move the endoscope in between the nerves, I fix it to a mechanical holding device. and then I have both hands free. But what is the problem is if you fix it and it's for a long time in front of these nerves, you have always to irrigate. Otherwise, the heat on the tip of the endoscope can really be a problem. So you have to irrigate them.
Sometimes you have to focus. How do you move the endoscope?
No, I don't move it. I just place it in the space and in the position I want to have it, where it gives me a good view and allows me to work under it. So
Right. Okay, excellent.
You have somebody who is experienced and you can move it in the safe way. Of course, that is also very helpful. But if you have a resident on your side and he has not done it, it's not a good idea to learn it with him in such a case.
Correct. And do you use 3D or 2D always?
2D. I'm still a fan of 2D. We had some 3D endoscopes, but for me, the 3D effect was an overestimation of depth. So when you look under the microscope, it's different. So it was really, for teaching, it's very nice because you can show it very nicely, the anatomy, but for surgery, I'm still prefer the 2D. And it's interesting, our general surgeons, they have a new unit, 3D endoscopes, but if you come to them in the routine, they always operate 2D. Just when they have the courses, they use the 3D. That's interesting for me.
Oh, excellent presentation. This wonderful technique you have shown of assisting by the endoscopes. Wonderful. And you are doing a great job, no question about it. Wonderful. Thank you.
Thanks for your comment. More questions on should I look somewhere or not?
Thank you, Henry. Thank you.
Welcome, Ben.
For your, yeah. Thank you for your nice presentation. And tonight there's 1,400 audience watched your presentation. Thank you.
Wow. How much? 1,300?
Yes.
Oh,
1,400. Yeah.
Amazing. So I hope we can meet in Greifswald.
Very good. I don't know if we have numbers of Japan. You don't have numbers in Japan, Akash, do you?
Yeah, I'm not certain about the rate around me. So the number is not certain, but I was very informative lecture for, and most of the many Japanese neurosurgeons are looking carefully, watching.
Very good. Geez, I've never seen everybody so quiet. Vlad, do you have anything to say?
Excellent, Henry. Beautiful videos.
Thank you.
How long does it take you to edit it?
Oh, it's not too long. But I would say it depends on the case. Sometimes for a petroclival, of course, you have many hours which you have to look afterwards. But in some of the epidermoids, it's sometimes an hour. Yeah, I would say 1 hour.
Yeah.
Okay, Juha.
There is one question. When you use 45 angle endoscope, do you have different set of instruments?
Please repeat one more.
When you used 45 angle endoscope, do you have different set of instruments?
Yes, of course. The tip is more bent, but it's sometimes I use the same instruments also for 30 degree. So you can use it on both. Of course, when you have 45 degrees, you need a little bit more longer angulated tip. It's the same with a bipolar. I have a bipolar with a long curved tip, and one has only a short angulated tip. Yeah, that is important. But for heavy facial spasm, for example, with 45 degree endoscope, you see much better than with 30 degree, because the compression is so far medial, and then you don't need retraction of the cerebellum. Yeah, but there's still improvement needed for the instruments, of course.
We have a question from Ricardo Gomez. Ricardo, do you want to ask the question? You want me to? Are you there, Ricardo? Let me go ahead and ask it. When you use a 45-degree angle endoscope, do you have a different set of instruments?
No, it is the same set, but I use the instruments with a longer angulated tip. So I have 45-degree and I have 90-degree tip, and some have only a short angulation and otherwise have a longer to reach tumor which is far away. And I have also a lot of bent suctions at the tip. I bend it, custom made, the Fukushima suckers, and then you can follow it, especially good for the epidermoids. You can reach an area which cannot be reached with the straight instruments, and also you cannot see it under the microscope. So for epidermoids, it's very nice. You can even resect tumor on the other side of the brainstem with this curved suction. These are ideal tumors. Of course, with a fibrous tumor like meningioma, it's not working, but for epidermoids, it's very nice with an endoscope. This is one of my favorite surgeries. If you have a good epidermoid, which gives a big cavity, everything is displaced, and you can really, from a small opening, resect a lot of tumor.
Okay, very good. Okay, Juha, do you want to wrap it up?
Okay, thank you very much. Thank you, Henry. Thank you very much. And thank you, Subin and Liao, and Takeshi Kon for translating. So next week, we will try with Professor Wygotsky again on AVM surgery tricks. And
very good. Okay, thank you, everybody. Thank you, Dr. Schroeder.
Yes, thank you for this kind invitation. It was a great pleasure to see you, and hope to meet you somewhere in China soon.
Okay.
okay.
Thank you. Thank you.
Thank you. Danke schön. Auf Wiedersehen.